I want to start because so many of the people at the table are interested in what many of which we've talked about in the call, which is that whole realm of innovation, what's in the pilot stage, how do we get things out there in the marketplace. I want to ask each of you, first of all, what's most exciting on your radar right now that you'd put on ours? And then we can get to the challenges, but let's just start with that and give us some teaser content to start the conversation. I'll start with you, Jeff.
My teaser, I learned early on in the Army that blunt trauma is a good motivator for change. And I feel since the pandemic, we've seen an acceleration of traumatic events in the industry, mainly around staffing and burnout, and access to care actually going down. And so as a med tech provider to hospital systems, I have an opportunity that I see to use what's on the truck today to work together to innovate in care model deliveries that we may not have even expected 4 years ago, and leveraging what we have today to really build upon that. We can't have the big bang, but there's a lot today we can do.
Yes, and thank you for your service. It's very important, so thank you for that. David, what excites you?
Well, as I think about kind of where we're at in the healthcare industry right now, there's some challenges that are ahead of us that, again, I'm not perhaps maybe as excited about. Now, we could take each individual state and look at our own unique differences and woes that we have. There's a lot that we're worrying about right now, whether it's staffing, simply getting enough individuals that want to go into healthcare, whether we're looking at inflation, whether we're looking at inpatient beds, whether we're looking at clinics, whether our physicians will use digital, whether we can use AI and employ it in a real way. There's so many exciting things that are going on right now. The question is what do we focus on? And I think that's going to be the challenge, and also the excitement. And I hope we talk a little bit more about some of the things that we're doing to try to narrow in and see some of the advantages and really benefits to what we're doing. But I'm excited about what we're in front. There is always something woeful in healthcare. Whether it's the Balanced Budget Act, whether it's DRGs, whether it's Obamacare, there's always the next thing, COVID. If we think about some of the challenges, and we are such a resilient industry, and we are here for what our patients need, that's what excites me.
Okay, good. And I love the fact you immediately hone in on priorities, ROI, what's going to make a difference. I think that makes for rich conversation. How about you, Francois?
Well, for me, thinking about something that we mentioned earlier, which is that we're all getting older. And the ability to address aging and think about, the optimal aging. And how do you do that? How do you think about individuals and providing care from that perspective? And it's not just the typical way in which we've done it, but innovating in terms of, again, optimizing aging. And one example, and I'll leave you with this teaser, that we know that as individuals age, obviously, like you can develop like organ failure, and this whole notion of xenotransplantation beyond just a typical way that we do it now, and just really thinking about how that will serve a variety of communities as well as addressing aging in a different way. So that excites me. I think we're very, very close.
Is that an Aura ring on your hand?
That is
I've
a wearable.
I've done a count. I've counted 17 Aura rings on CEO hands in the past month. So which is interesting.
Kind of a big deal.
Well, it's also because sleep. They're recognizing sleep as a sort of a strategic advantage, and maybe it's just a fad, but it does say something about our changing attitudes to health.
I'll tell you the other reason that I absolutely love this. I am fascinated with data. And this thing gives you a lot of data.
What's your sleep score today coming into this conversation?
You don't want to know. That's a different idea.
We'll get to that after. Well, let me go ahead. I want to ask about the challenges. So let's start with that. But you were going to add something too?
I wanted to just try to make it very real and tangible, your thought about aging. Tonight, as I'm sitting here, my wife is in South Alabama with her parents. Her father's dealing with congestive heart failure. Her mother is dealing with some serious memory issues. She has been driving 5 hours every week to go care for them. Can't do it anymore. They're finally at the point they need to move to Nashville with us. So she's bringing them up. I'm helping them move in next week. So I'm thankful that this was this week, not next week.
Yeah.
But they don't have access. I mean, these are well-off people that work really hard their whole lives, and they just don't have access to the kind of care they need, despite all the telehealth things that they've been doing. So we got to help people everywhere in life journey. I was really moved by your statement there, so I just kind of wanted to share that.
Well, and it does get to the challenge, doesn't it? Because we get very excited about some of the advanced, capabilities that we see in technology, but so much of the challenge of the healthcare system is that kind of meat and potatoes. I need care. It's not, the latest advance in heart surgery. It's can I get to my doctor's appointment, et cetera. So what would you say are some of the challenges that you're thinking about in this?
Well, I was sitting with a CIO several months ago, and he said he was talking about technology in kind of general terms. He was talking about various things that were coming at him and different vendors that have solutions. It's like it's death by 1,000 cuts. I need someone to help me orchestrate this. So the challenges that we get, by the way, we're here because of the Future Health Index that we're all going to give you a sneak peek about 12 hours before we go public. So
yes, you do.
Special.
And we'll talk about that because it's actually quite interesting to see the U.S. in the context of other countries too. How about yourself? You talked about some of the challenges. Are there particular problems that are most critical to solve that you think are the most perhaps far off?
Well, again, when we think about some of the things that we're worried about right now, care at the end of the day comes down to the individual interaction between the patient. I loved your comment about thinking about how do we better enable our nurses, our physicians, our caregivers. The use and employment of technology, I hope, and as I spoke about, should be an enabler, but at the end of the day, it doesn't take place of the relationship between the caregiver and what will actually be provided. Again, I think about something that happened this week. We've got something that was new, a program at Sandford, which is called TILs, temporary infiltrating lymphocytes, which again is a new way of caring for patients in a different way. I can talk about Atropos, which is our latest AI technology that allows you to get a second opinion with 1 million different data sets. But quite frankly, TIL has more of an opportunity to make real pieces. So if we're going to employ technology in a way, how do we identify what we need from being able to do that? And I think that's where some of the challenges lie. And have we done a good job of identifying what we could actually be better enabled with and what we're using and started to identify those? We talk about, one of the things we talk about, all the little shiny things that are out there that grab our attention. There's a lot of them. And I would say probably the leaders around the table here are probably getting inundated with a lot of different ideas. And the question is, how do we go back to really saying what makes a difference for our patients is really going to be able to make an impact? There's a lot of things here in those opportunities. It's just honing on what those are.
And we'll talk more about that. How about for you, Fritz?
Yeah, we talked about the challenges for organizations, but as I think about the challenges and how we adapt, I mean, we are a very large integrated academic medical center. And we thought about this question of access from the perspective of what are the challenges for patients and communities? And should we really think about this in the context of bringing the care to them as opposed to assuming that patients will always come to us? So here's a question for all of you to think about. The problem that we face was that, is it possible to literally take a failing community hospital that is in an area with the highest Medicaid population in the country and transform it? Well, immediately you might say, well, no, that's crazy. Why would you want to? So we actually thought about this because, again, we wanted to bring the care to patients and communities. And the hospital I'm talking about actually used to be known as Lutheran in Brooklyn. And we did that with the idea that it was going to be the same standard and focusing on quality and safety. And believe it or not, we've been at this since 2016. Believe it or not, they have one of the lowest mortality rates in the country. And not only that, it is the only hospital in Brooklyn to have an A safety rating by Leapfrog. So that transformation in terms of what is possible when you think about bringing the care and making investments in the communities as opposed to
And the transformation was moving kind of that inpatient experience out to...
Absolutely, not only in terms of the hospital, but also school-based clinics, as well as working with communities and community health workers to think about the needs of the patients. If they get admitted and they're discharged, well, what happens thereafter? So that's been the type of investments that we have made with the idea that we know that not all patients are going to come into Manhattan. We want to go out to those communities.
Well, I want to talk about the Future Health Index, but let's pause on this for a second to see if any of the two of you have comments on What is the future of that kind of inpatient hospital experience? So much of the technology we're talking about enables in-home, enables new centers, but yet it creates new challenges around, you know, the payment models, the control models. How is that playing out from where you sit, either of you?
I'll take a first stab. And first of all, I was in with Fritz's team just a few weeks ago, and watching what they do on the ward. Like it is mind-blowing, the innovation they have to save minutes off a nurse's hour. Minutes. What they can do on a phone from the beginning of their shift to the end of the shift. They've changed, they've taken all the menial activity out, the redundant, the hand typing, all those things that you say, well, that's probably, you get a 10% bang on that. But the value to the nurses, because that's 10 minutes more an hour they're spending with their patients. And that's really what they want to do. So there's I saw the human satisfaction in approaching that. And the reason I bring this up is because it's digital capability that exists today, and you all have invested in that. In the same way, David, with Sandford, in so many of the ways with digital pathology and some of the AI work that you're doing that we get to participate in with you, because we know it takes a team to do it. It can't just be providers, it can't just be technology, it can't just be the reimbursement's a part of it, but a lot of the things that happen in the walls of the hospital, we can really make pretty slick and make a better patient experience.
Yep.
And improve staffing satisfaction and lower the burnout as well, which is, you know, if you get to the report, it's a pretty big freaking deal here in the U.S.
Yeah.
What's happening to our healthcare workers.
And that's absolutely correct, Jeff. You know, what Jeff was referring to is that we have paid a lot of attention to not only how every one of our rooms are designed to save time for nurses, where instead of having to go back to an area, for instance, to get medications, there is literally a digital medication drawer right at the door that is where you can put your fingerprint as a nurse. It opens it up because the medications were already delivered. Saves time. You're not going back and forth. You also reduce error in terms of, you know, like thinking about how you're giving that insulin medication to your patients. Moreover, the entire focus, think about the design, is to bring the care to the patient. We don't move patients. So what am I talking about? Well, think about the acuity of the patient, whether they're on acute versus ICU, but you don't move the patient. So we have acuity flexible beds. We come to the patient. The team comes to the patient. Saves time and reduces a lot of waste when it comes to workload. And yes, you're right. The devices that the nurses use allows for better communication. We deliver information to their devices, even alert them when a lab is ready. They'll get that notification right there. They don't have to go to another computer. Again, it's all about efficiency, about safety.
Yeah.
So.
Is there anything you want to add, David?
Well, what's interesting, I remember going through grad school, which was quite a few years ago, who everybody said the inpatient hospital is going away, that it's dead, we'll not have it. What we have seen in every organization of the 4 places I've been, I've built a new inpatient facility, and so it continues to grow. The question is, and I like what Fritz said, and Jeff as well, how do you scale the technology that we put into these spaces so that we have the ability to actually treat the patient in the area that they're at? For example, we can now do an online e-consult for our patients, because not all the time do we have the ophthalmologist, the nephrologist, all immediately available. Because of the technology you now have in the room, you can do that e-consult right there immediately so that you don't have a patient waiting. Same with the ability to do the pharmacy, the meds, those pieces that allow that.
Yeah.
So how do we start to pull in some of these technologies? The EMR is just a great data resource right now. How do we start to use that to actually be part of the decision-making process? And that's what we're doing. And I love that you brought up what we're doing with you with digital pathology. We've now, everything in the hospital is digitized. And so you can bring those films up or slides up real time so that patients and doctors can see them right there. So a lot of scaling of the technology enablement in the areas. So
it's exciting to think of some of the devices too now where doctors can perhaps not look up but get so much of it served up to them. I want to ask about the your latest Future of Health Index. It's your 9th year. I think putting the U.S. also in the context of other countries is interesting, like, because sometimes we don't get out much with these things because it's a big country, there's lots to talk about. Yeah. What are some of the findings this year you think are interesting and germane to this?
Well, I'll draw out the first one, which I think really paints U.S. healthcare in quite a different light. You think about the nature of this. It's the 9th survey. It's fairly well known. 3,000 of your compatriots globally do this in 14 countries, many of which are kind of economically mature countries. And so 90%, 9 out of 10 practitioners that took the survey said that mental health and well-being and burnout was actually impacting their ability to deliver care because of staffing shortages. That's remarkable. Think about 1 out of 10 is like, it's pretty good. 9 out of 10 have a concern about the long-term burnout effect. We're not having people add to the ranks as much as we're having them leave the ranks, right? So the second big thing, 8 out of 10 have said they feel a direct tie to the ability to deliver quality care as a result of that staffing shortage. 50% said 50% of the respondents said we actually are reducing our capability to reach underserved communities. It's a passion of ours. It's a passion of many around the table. We're actually lowering that capability. When I look as a technology provider, what we can do, I think, gosh, there's got to be a way to work closer together. Now, Diane, to your point, and the last one I'll make on the sort of the challenges, the U.S., that 90% I referenced, is twice as much as anywhere else in the world. So we're experiencing burnout in our ecosystem twice as much by our own respondents, our own people, than anyone else in the world.
Or why do you think that is? I should
Well,
ask
these guys.
Why do you think that is? Why are we sort of uniquely ill-placed?
I think part of it, quite frankly, is there's a little bit of an overwhelming aspect of the technology that we're using, a little bit overwhelming aspect of the care that's being provided, a lot of the intensity, the volume, the things that are there. But I think, it's something that we've got to be focused on in a very different way that we haven't before.
Yep. I want to ask, I know that we want to, I feel like we could be talking all evening, and I want to give a chance if anybody has any questions too, but I want to go to both of you, and whether it's the levers that you think are proving especially effective, but maybe more from an advice perspective, what have you found actually moves the needle, in terms of, you talked a little bit about some of the innovations that you're doing, but if you were to sit back, what problems are you solving that you think would be relevant to the problems that the people at this table also have? Or what problems, are on the horizon that we can solve? Yeah. I know it's a big question, but do you want to weigh in?
Fritz, you want me to start?
Sure. I'm happy to start. I think we touched on this notion that the volume is increasing. And we made the assumption post-pandemic, we were talking about this, that perhaps the EDs would be quieter. Nothing could be further from the truth. That we're busier, and yet the pressures of being more efficient are there. And so from the perspective of thinking about, how do we do this better in some ways, and the use of technology, you're right, can be overwhelming. And so what we're doing is rethinking the way that we're using this. And to give you a concrete example of what I'm talking about, think about the work, what the bedside nurse will do, and all the various steps that they have to do. And we've thought about this in terms of, we're about to roll out what we're calling a virtual nurse, which essentially is a live nurse that is going to be able to do the initial assessment and saves the time of that bedside nurse to do something else, frees up sometimes, makes it a little bit more efficient, reduces that pressure on that individual. It sounds simple, and yes, it's an investment, but if you're that bedside nurse, think about what that means for you, of having that kind of support. So it's one example in which, in terms of how are we taking a bite out of all.
Excellent. And we're talking a lot about staff. It's a multi-stakeholder environment. Obviously, we've got insurers, we've got employees, we've got patients. Are there any, let me go to you, also doctors. How is the technology, we haven't talked about all of the stakeholders, and I know we have to, I want to give, it's funny, we're going to have a chance to sum up here and then move the conversation to the table to hear from all of you, but what about some of the other stakeholders you think about in terms of the impact of technology and the levers that you're looking at?
Well, again, I'll use that since you brought it up. I mean, the faculty or the physicians at Stanford, on average, before COVID, used telehealth 2% of the time. Of course, during COVID, we were up to 79% of the time, and now we're settled in about 34% of our visits are, again, we are probably one of the highest still in the country. So how long does a telehealth visit on average take? 21 minutes. How long does an in-person visit take? 67 minutes. We are 2/3 more likely to be able to have a higher patient experience score, quite frankly, if they have a telehealth visit because of the fact that you don't have to go find parking and all the other things that go along with that. We then employ other technologies like voice automation, like what we've been doing with some of the technologies that actually then can scribe a note for the physician. If you look at some of the things that we're doing with, we use DAX with Microsoft, the reality is about 20% of all the notes that are scribed coming out of the inbox are actually used. So that means 80% are not. So the reality is the physicians are saying this is still better than, I don't have to use the cognitive load to actually draft the note. So in terms of enabling the physicians, whether it's telehealth, allowing them more time and access to the patients that they can't get to, whether it's the technologies that actually can save them time, I think there's a lot in the pipeline that allow us to improve that.
Now, I know from experience that well-fed people make for a better conversation. So I'm going to give each of you a chance to give some very quick closing thoughts, and then we'll move this conversation to the table where we'll have a wider discussion. I'm going to start with you.
Sure.
Closing remarks.
I think quickly, AI is amazing. I think that the potential to do things for our physicians, as an example, improve quality and safety, is something that we are absolutely committed to and looking forward to in terms of its transformative nature.
David.
Yeah, same thing. I think technology is something that's on the future. It's on the horizon. How do we make sure that we take advantage of it and pick those things that are going to best enable our physicians, staff, the ability to do better work? I do think I'm excited about and very bullish on what we have in front of us.
And as a technology service provider to all of you and the innovation you're trying to do for that people and patient-centric design and delivery systems, we're wanting to walk that journey with you end to end, because technology of itself is not enough. Your network is insufficient by itself just with the providers, because we think there's a multiplicative effect. Everything we're designing today in Philips is to take a piece of technology that you can use and extend the care or the highest level of licensure of a human being, of a care provider, into communities with maybe a lower level, but that you can have that collaboration live and meet the requirements and the quality that you want, and keep extending that care at a lower price point.
Exciting stuff. We're going to continue the conversation at the table. We want to hear from all of you. As the daughter of a nurse, I also thank you, because I know full well, oh boy, did I hear stories from my mom. So thank you very much, Fritz, David, Jeff, and look forward to a great meal. Thanks everyone for listening. Diane.